Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas.
Hello, everyone, and welcome for today's Quorumcast session, which is about cardiac arrhythmias, palpitation, syncope. So we will go through these topics and we will discuss some of the key elements, and also I will outline one medication which is very commonly used and sometimes not very well understood the effects. So this will be at the end of the session. We will discuss adenosine. First, we will start with palpitations and then go on to syncope. Palpitation, what is it? Is it usual? Is it a very severe symptom? Of course, it's a benign symptom. It's like experience of all of us daily. Most of us have some palpitations, which is completely normal and requires no medical attendance at all. If the palpitation has some specialties, which we will just discuss, then the medical attention and maybe visiting a cardiologist is required. So what is palpitation itself? It is the feeling of our heartbeat. So in general, you are just sitting there at your desk or driving your car or commuting. In general, you do not feel your heart beating, and that's normal. But it's also normal to have like 2 or 3 beats a day that you feel that, oh, it was a quick beat, or oh, it was a strong beat, like a jump. When it's really in low numbers, then that's also normal. Let's see what kind of questions would you like to ask to get a whole picture, to get the diagnosis. So you would like to clarify what is the feeling itself. Is it a jump? Is it an irregular feeling? Is it a really fast rhythm? And from these, you can get to the essence. Usually, when people say that, oh, it's a quick, or oh, it feels like my heart is stopping, it feels it's a really, really strong one, really strong beat. These kind of symptoms are usually extrasystoles, and are usually ventricular extrasystoles. When a patient is saying that, oh, I'm lying down and I feel like my heart is running and it's just getting out of my chest and it's really quick and I can't really handle, and sometimes I also feel breathlessness. Those kind of symptoms are rather suggesting a tachyarrhythmia, maybe an AVRT, AVNRT, or an AFib. Okay, then you would like to require more about the pattern. What is the onset? Is it a slow onset? Is it really sudden? Is it related to any physical exertion? Is it related to stress, anxiety? Then you require about the frequency. How often does it occur? It's really useful to determine the impact on the patient. Then you ask about the duration of the symptoms. Is it just really a brief couple of seconds, several minutes, or is it continuous during the day? Then you can rule out a couple of arrhythmias. If the patient says that it's a continuous thing during the whole day, then it's unlikely to have a continuous AVRT going on through the whole day. Okay, and you would like to ask questions about the associated symptoms, such as angina, such as a syncope or a fainting, such as breathlessness, dyspnea, and also, of course, about the histories, the first time, were there previous episodes, is there any heart condition which is known for the patient. Okay, and if you have this whole mosaic, this whole picture, you are a step closer for your proper diagnosis. Of course, 12-lead ECG, and not in all conditions, but in a cardiology department, a 24-hour tape recording usually performed if the symptoms are suggestive of arrhythmia. What could be the causes of palpitation? 2 major groups are the cardiac and the non-cardiac causes. Of course, the cardiac causes include tachyarrhythmias, I've just mentioned the atrial fibrillation, then atrial flutter, supraventricular tachycardias like AVRT and AVNRT can cause, and also ventricular or atrial ectopic beats. Another bunch of the conditions are the non-cardiac causes, such as sinus tachycardia for any non-cardiac reasons, such as pain. For example, it could be a menstruation pain, it could be gallbladder pain, it can be a headache. Others are anxiety, fear, any infection, mostly in the elderly population. A slight infection can result in tachycardia, hypovolemia. Anemia is really important and really frequent among youngsters and among ladies who are in childbearing age. Some more specific or more complicated reasons are related to the thyroid glands, such as thyrotoxicosis, which I've seen, as I remember, like twice, I think, on the internal medicine department. So it's not so frequent as so much we learn about it during our medical studies, but it exists. And some other rare conditions like pheochromocytoma, which is a tumor producing adrenaline, extremely rare, but it exists. Okay, so this was the first part of today's session where we discussed palpitations, and we discussed how would you like to get a whole picture from your patient about the underlying condition. Then we can jump to our next topic, which is syncope, and of course it's really closely related to palpitations. So syncope, by definition, means transient and sudden loss of consciousness, usually leading to fall. True syncope means that there is a loss of consciousness, and it's important to differentiate a true syncope from a benign collapse or a benign fall. But it's also important not to overlook a severe condition by an elderly patient just saying, oh, it was just a bad step, or it was just on the corner, I couldn't really took that step and I had a fall. And it turns out that it was a severe syncope, and they spent who knows how much time on the floor before recovering. So taking the history is really key to diagnose a syncope. And also, if you have any bystander, then use them and let them tell everything. And I will again discuss what kind of questions you have to ask to get a whole picture. In ulcer conditions, I would take a really, really close eye, and I would handle any suspicious case as a syncope, which counts as a syncope, or where there's a possibility of a previous syncope. Because if it was a true syncope, it can be repetitive, and it can have very severe underlying cardiac conditions. So I would keep a really close eye and close monitoring of the patient in ulcer conditions, because I would count with the repetition or the worsening of the whole situation. So just as like palpitation, syncope can have cardiac and non-cardiac causes. Cardiac reasons, of course, severe arrhythmias result in syncope. We also have some cardiac reasons which are not arrhythmias, and I would like to discuss these. Mostly the obstructive valvular disease. What does it mean? It means that there's a valve stenosis, a narrowing of a valve, mostly the aortic valve stenosis, can result in a symptom as a syncope. Then hypertrophic cardiomyopathy is a genetic condition when the heart is hypertrophized and it has a pathologic contractility function, and sometimes there is a severe hypertrophy resulting in a stenosis in the left ventricular outflow tract, resulting in a syncope. Mostly these patients, they are diagnosed around the adolescence ages. so in the teenagers, and they know that they have this heart condition. I also tell you that if it's a severe syncope due to hypertrophic cardiomyopathy, there's not much you can do on the field in oyster conditions. Of course, you monitor the patient. You have to give fluids to maintain a very good euvolemic state to reduce the risk of this obstruction in the left ventricular outflow tract. And if you see an arrhythmia on the monitor, then you manage that with either with pharmacological treatment or with cardioversion, or the situation worsening, then CPR, of course. Other cardiovascular non-arrhythmia resulting in syncope could be an aortic dissection, could be a pericardial tamponade, could be pulmonary hypertension, pulmonary emboli, and also some very rare cardiac tumors like an atrial myxoma. Let's also talk about the non-cardiac causes. We have the neurally mediated syncope, which is a vasovagal syncope. By definition, this is the classic fainting when someone is standing for too long time, or when someone is just jumping up from sitting low, and it's the vasovagal reflex is not quick enough to get used to this new situation of being up, or for being upheld for so long time, or being in an upright position for so long time as long standing. And by this reflex, there is a slowing down of the heart rate, and then a faint. And the faint is like resulting in getting back the normal physiologic condition from the legs. And lots of blood is just getting back to the heart. There is preload again for the heart, and then again normal circulation. So this is the pathophysiology of a collapse by definition. Which is also called an orthostatic hypotension. But sometimes it's not just a physiologic reaction. An orthostatic hypotension can be drug-induced, can be a result of the volume depletion, or can be, for example, as a co-symptom of Parkinson syndrome. So there are many, many reasons behind fainting and syncope. Okay, so let's jump back how to get most of the situation to get your best diagnosis. And you would like to ask question and inquire about the three Ps, like provocative factors, prodromas, and postural components of a syncope. So 3 Ps, the provocation, prodrome, and the postural condition. So you would like to know some provocative factors such as fatigue, dehydration, warm atmosphere around, emotional circumstances, some fear, some pain. You ask about these. If the patient can tell you, then the patient or the bystanders. Then the next P is the prodrome. What was there any, if any, previous symptom prodrome? Could be a nausea, could be sweating, could be some abdominal discomfort. And then you also ask about the post-oral components, such as the patient was found lying unconscious for a couple of minutes, or the patient was still standing. Could be that they tell you that they had a syncope, or there was a blackout. It could be an epilepsy when the patient remains standing but has the feeling of a blackout, or has the feeling of a syncope. Or the patient was sitting and didn't fall off the chair. So these are really important details of the whole circumstances to get the diagnosis. Very important how long the episode lasted, just seconds, minutes, longer. And then if you are in oyster conditions, of course, you perform an ECG. If the underlying pathomechanism lasted only for seconds or minutes, then you might miss the whole pathophysiology or the whole pathogenic mechanism on the ECG, and you can have a completely normal one when you are attending the patient. That's the thing that is happening at most of the syncope patients. So again, as I just mentioned before, I would advise you that in oyster and remote conditions, if the whole situation looks like or feels like a syncope, then handle it as a syncope and not overlook as a simple faint or a simple fall, because mostly in resting conditions the ECG will be normal. Of course, you don't have a 24-hour tape recording possibility in remote conditions. It might happen that a patient is 24 hours with you there, and you have a continuous monitoring. Then you have a so-called 24 hours tape at your hand, so you can, and you have to monitor a patient with a supposed syncope. So that's my advice, to handle it as a syncope and not overlook a more severe condition. I would like to, from here, touch on some diagnostic steps which can be performed in remote conditions as well, and can lead you to a very, very good device diagnosis. So a carotid sinus massage. It's easy to perform, but I would recommend to do it with caution. And if you don't have the required information, then do not do it. So what is a carotid sinus massage? On the carotid bulb, you require pressure with continuous ECG monitoring, and if the patient is suffering a bradycardic episode or an AV block or a systolia, then you have the diagnosis at your hands. You have to have medications and equipment around to be able to perform a CPR as needed, because the patient can go into asystolia and there's no promise that they recover on their own. What is the mechanism? Again, it's the carotid sinus, the vasovagal reflex, and the carotid sinus, the bulb itself, is too much sensitive for pressure, and results in an overstimulation of the vasovagal reflex, resulting in too much bradycardic episode. It could be a severe bradycardia, an AV block, or an asystolia, as I just mentioned. Mostly elderly men have this condition, and when these elderly men shaving themselves in the morning, that's the most frequent time when these kind of syncopes happen. So it's important to get the image again, what was the surrounding atmosphere, what they have been doing when it happened. But of course, it's not compulsory to have an elderly man. Others can also have carotid sinus hyperesthesia, as we just call it. Those cases were the most frequent I've seen. Okay, it's really important not to deliver a carotid sinus massage if there's a possibility of a carotid atherosclerosis and the possibility of a carotid plaque. So if you see, or if you just mentioned that elderly man and carotid atherosclerosis, I would say that they go hand in hand. At least in my environment, it goes hand in hand. So most elderly men have carotid sinus or carotid atherosclerosis. So for this reason, make sure and ask them, and ask about medications they take, ask about lipid levels, cholesterol levels, if they know if they have a carotid ultrasound, then read the report, etc. So make sure you don't perform carotid sinus massage on a really atherosclerotic carotid artery, because you can cause a stroke just by mechanically damaging a plaque, which can just flow into the brain. Okay. Another diagnostics or diagnostic steps is not so risky, or no risk to cause any harm. It's an orthostatic test. When you measure the blood pressure in the lying position, then the patient is standing up, and you measure within 3 minutes. And if there's more than 25 millimeters of mercury difference in the mean arterial pressure, it's suggestive of orthostatic hypertension. More sophisticated diagnosis is the tilt table testing, but for that you need a special equipment to perform. You need to tilt the patient when the patient is lying, and you do the same measurements. Okay, these were some specific diagnostic steps for syncope. At the third part of today's session, I will jump to arrhythmias. And by arrhythmias, it could be like whole day talk. Sure. So before today's session, I was thinking of what were my challenges when I was working as a paramedic, or what are those situations, what I just seen and what I see at the cardiology department nowadays, and what kind of discussions we have with the paramedics bringing in the patients. So yeah, and then I decided that I will talk a bit about adenosine and arrhythmias treated with adenosine. So what is adenosine? Adenosine is an anti-arrhythmic drug. It's really important that adenosine is a really, really short-acting drug. The half-life is like 2 minutes, and within that 2 minutes, it needs to reach the heart to get to those cardiomyocytes, which are generating the arrhythmia. And within those 2 minutes, the concentration of the drug in the blood has to be so high to be effective. So in my practice, I've seen and I believe that adenosine is widely used, but it cannot be as effective as we want it to be. So you want to administer it really, really quickly into a vein which is close to the heart, which allows good flushing. You want to flush it with some saline quickly. And when adenosine works well, so when it's truly effective, then it's a really unpleasant sensation for the patient, because it is just terminating a tachyarrhythmia, and they really feel bad when this thing is happening, because it's like a feeling of truly stopping the heart. But then they get really quick relief, and then the normal sinus is back. So adenosine, this drug is acting on the AV node, and this drug is terminating the conduction of the AV node. So means that stops the conduction of the AV node in the heart. You can yourself think about what can happen in an arrhythmia if the AV node is out of the game. So there's something going on, and you want to think this way when diagnosing and when treating arrhythmias. So you have your atria, or the patient has 2 atrias, 2 ventricles, and the bridge, the AV node in between. And you also have the sinus node. I would say that the sinus node is the good guy. He is either doing the work or not. If doing, then it's okay. There's the beautiful sinus coming from the sinus node. If not, then and the patient is alive, they might have a pacemaker, and the pacemaker is doing the job. So, and after all of this, the sinus node cannot play in the bad circle. But the AV node, I believe the AV node is the most tricky part of the whole heart in terms of eliminating arrhythmias, initiating arrhythmias, bridging the atria and the ventricle, or not bridging at all. So the AV node is a complicated guy, but you want to understand. Okay, so the adenosine blocks the conducting tissue of the AV node. And in today's session, I would like to focus on the effects of adenosine in different arrhythmias. And from this discussion, I try to mirror you that what are those arrhythmias you want to use adenosine and what are those when you have to avoid. So you have a sinus tachycardia, which cannot cause a syncope. Sinus tachycardia, and you administer some adenosine to your patient, and you do it really in a handsome way, and it's effective. What will be the effect? So there will be a transient slowing of the sinus rate because of the transient AV block, and also the adenosine has some effects on the sinus tissue. So that's all. So the normal sinus will be a bit slower. Okay, no panic, it's all right, but you don't administer adenosine to a sinus tachycardia. If you have an atrial tachycardia, so an atrial tachycardia, so it's not an AFib, it's an atrial tachycardia, you either diagnose that on a 12-lead ECG or not, or the patient has some device and it's noted before that they tend to have atrial tachycardia, so you know that it's an atrial tachycardia, and you administer adenosine. So there will be an AV block, and the atria will have its tachycardia ongoing, and the ventricles, it depends if they can accommodate and they can generate some escape rhythm, and then they are happy. But if they can't, then you have to do the job, because then the patient is in a big trouble. Okay, what about an AFib? So with an AFib, again, the same is happening. So there's an AV block, and the atrial fibrillation will go on. What happens if there's another conduction system other than the AV node, which is happening in AV node reentry tachycardias? Then the atrial fibrillation will simply go down to the ventricles in 1-to-1. So the ventricles will be in fibrillation, and you just generated an FBI tachycardia by simply administering adenosine. So you can kill a patient in an atrial fibrillation if you administer adenosine. So that's completely contraindicated. Okay, I would say that if you experience any irregularities in a tachycardia and there's any slight suggestion or slight suppose of an atrial fibrillation, then avoid the use of adenosine. You can turn to other antiarrhythmic drugs, but the adenosine is a potent and prompt blocker of the AV node. So the patients, I think they won't survive if you generate an FBI tachycardia. Most patients are not in so much risk. Again, I'm just turning back that frequently adenosine is not administered effectively, and that's the reason some patients still survive if administered on an atrial fibrillation. So be careful. The AV reentrant tachycardias and the AV node reentrant tachycardias are the indications for adenosine. So it's the tachycardia will terminate and sinus will return. What about a VTAC, ventricle tachycardia? And you administer adenosine, usually nothing happens. If anything happens, then it's not a true VTAC. Then the AV node is somehow included on that tachycardia. Sometimes, if there's a high bundle VTAC, I mean high from the his Purkinje bundle, very high, located really close to the AV node, then the VT might terminate, but mostly nothing happens again. So avoid use of adenosine in a suspicion of an atrial fibrillation. That's the conclusion. And with this, we are reaching the end of today's Quorumcast. I hope that this summary on palpitations, syncope, and some antiarrhythmic drugs, these were useful for you, and I could give you some useful points to diagnose, how to ask the questions, and also some key issues on the use of adenosine. Hope you enjoy, and stay with us and stay tuned for our next session as well. Bye-bye.
This has been a presentation from the College of Remote and Offshore Medicine Foundation. If you would like to earn CPD credit for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credits, free access to the virtual field guide, and discounts on our e-learning courses. You can join the team on the college website, which is Corum, C-O-R-O-M, corum.org.